Today we're going to be talking about aortic insufficiency. This is a complete aortic regurgitation masterclass designed for beginners. We'll build everything step by step, all the way to registry level measurements. By the end of this video, you'll know exactly how to identify, measure, and grade aortic regurgitation with confidence, clinically and for the registry. Take a look at this registry prep slide. Don't memorize it yet. By the end of this video, every single line on this slide will make sense. The registry doesn't test aortic regurgitation randomly. It tests patterns. If you understand why any of these findings makes AR severe, you won't miss these questions. So, what exactly is aortic regurgitation? This pathology, also called aortic insufficiency, is the backward leakage of blood from the aorta into the left ventricle during diastole because the aortic valve doesn't close properly. In this loop, normal flow moves forward during systole with no blood leaking back. In contrast with aortic regurgitation, when the valve should be closed, you can see blood leaking backwards from the aorta into the left ventricle during diastole. That backward flow during diastole is what defines aortic regurgitation. So now, let's compare and contrast AR versus aortic stenosis. Remember, aortic stenosis blocks blood from going forward. Regurgitation lets blood leak backwards. One causes pressure overload, the other causes volume overload. For registry purposes, let's talk about the type of murmur that will be heard and the symptoms. Clinically, aortic regurgitation causes a high-pitched blowing murmur during diastole, usually heard best along the left sternal border. And both the timing and the type of murmur are things the registry may ask about. That sound comes from the same thing you're seeing on Doppler, blood leaking back into the left ventricle when the valve should be closed. For your board exams, it's also important to remember that severe aortic regurgitation can produce what we call an Austin-Flint murmur at the apex. This is a classic testable association of this disease. If registry-tested concepts like these help you, subscribe. I break these down every week. Now, let's talk about the most common symptoms. Dyspnea. This is shortness of breath, trouble breathing, or if the patient tells you that they feel winded. Fatigue. This is when the patient tells you they feel like they have low energy, they get tired easily, or they have reduced stamina. Palpitations. This is where the patient tells you that they're aware of their own heartbeat, they feel like their heart is racing or pounding, or they can tell whenever they have irregular heartbeats. Angina. This is when the patient complains of chest discomfort, pressure or tightness, or pain with exertion. Heart failure. This is when the patient's heart can no longer keep up, the patient is going to have fluid buildup and worsening shortness of breath. Next, I'd like to talk about major causes of aortic regurgitation. The most common causes include degenerative valves, bicuspid valves, aortic root disease, rheumatic heart disease, and infective endocarditis. Sometimes the valve is normal. The aorta can be the problem. So let's talk about the best echo views. When you're assessing aortic regurgitation, you should never rely on just one view. Your go-to views are the peristernal long axis, the apical 3-chamber, and the apical 5-chamber. These views give you the best look at the aortic valve and the left ventricular outflow tract, or the LVOT. But when you're thinking about severity, you also want to include the suprasternal notch view, because that's where you'll check for flow reversal in the descending aorta. No matter which view you're in, always make sure your Doppler beam is as parallel to the regurgitant flow as possible. Poor alignment is one of the most common reasons AR gets underestimated. Now let's talk about what you'll actually see on a 2D echo. On echo, aortic regurgitation causes the left ventricle to enlarge. Early on, the LV looks hyperdynamic, but over time, the pumping function can drop. You'll usually see poor aortic valve closure, a dilated aortic root, and in some cases, flail or prolapsing valve cusps. So let's talk about what you will see on M mode. Severe aortic regurgitation can cause diastolic flutter of the anterior mitral valve leaflet and even premature mitral valve closure. This flutter occurs when the regurgitant aortic jet strikes the leaflet during diastole, causing it to vibrate. Remember, this is a flow-related finding, not a primary mitral valve abnormality. Now let's talk about color flow Doppler. Color flow Doppler is where you start, not where you finish. Turn on color and focus specifically on diastole. You're looking for blood leaking from the aorta back into the left ventricle. At this stage, you're identifying the direction of the jet, seeing whether it's central or eccentric, and making sure you zoom in on the aortic valve and the LVOT. Large eccentric jets may hug the LV wall. One very important point for both real life and the registry: you do not grade aortic regurgitation severity by color jet size alone. Color is just the roadmap. Now, let's walk through how you actually measure aortic regurgitation on echo step by step, because this is where a lot of people get overwhelmed, but it doesn't have to be complicated. The most important thing to remember is this: there is no single measurement that grades aortic regurgitation. You always use multiple views and multiple Doppler parameters. First, we will talk about Vena Contracta. Identify the narrowest part of the jet just below the valve, and it represents the true size of the leak. This is best measured from the peristernal long axis, or the apical 3 or 5 chamber view. Zoom in tightly, lower your color scale to about 50 to 60 centimeters per second, and measure the vena contracta perpendicular to the direction of flow. A wider vena contracta means a bigger hole and a more severe regurgitation. Take a look at this table here. Remember, vena contracta is the true hole size. Bigger means worse. For aortic regurgitation, measure the narrowest portion of the color jet just below the aortic valve in diastole, using the peristernal long axis view with color Doppler zoomed and the Nyquist limit optimized. Remember to measure inner edge to inner edge at the vena contracta, not the jet length. A vena contracta less than 0.3 centimeters suggests mild AR. 0.3 to 0.6 centimeters suggests moderate, and greater than or equal to 0.6 suggests severe aortic regurgitation. Now let's talk about pressure half-time and how to measure it correctly. Remember, pressure half-time tells us how quickly the pressure between the aorta and the left ventricle equalizes during diastole. To measure pressure half-time in aortic regurgitation, place continuous wave Doppler directly through the AR jet, typically from the apical window, which can be apical 3 or apical 5 chamber, where the regurgitant flow is most parallel. Take a look at the continuous wave Doppler waveform on the screen. Because aortic regurgitation flow is moving towards the transducer during diastole, the Doppler signal will typically appear above the baseline in most labs. Note the signal position on each waveform. Once you have a clean spectral signal, trace the deceleration slope of the diastolic velocity envelope, starting at the peak early diastolic velocity and following it downward through diastole. Watch how the slope changes from mild to severe AR. Do not trace the systolic portion, only the diastolic regurgitant envelope. After tracing, the system will automatically calculate the pressure half-time for you. The pressure half-time value will be displayed on the tracing. Here's a key concept to remember. Pressure half-time reflects how fast pressures equalize. Rapid pressure equalization equals short pressure half-time, which means more severe regurgitation, or steeper slope when you look at the waveform. Slower pressure equalization equals longer pressure half-time, which means less severe regurgitation, or a gradual slope when you're looking at the waveform. So in short slope, short pressure half-time equals severe aortic regurgitation. Take a look at this table right here. Remember again, with pressure half-time, the faster the pressure equalization occurs, the more severe the regurgitation. To measure pressure half-time, use the continuous wave Doppler aligned through the aortic regurgitation jet. Allow the system to calculate the pressure half-time. With mild aortic regurgitation, pressure equalization occurs slowly due to a small regurgitant orifice. This produces a shallow deceleration slope and a long pressure half-time, typically greater than 500 milliseconds. When it comes to moderate aortic regurgitation, pressure equalization occurs at an intermediate rate. The deceleration slope is steeper than mild but not abrupt, with a pressure half-time usually between 200 and 500 milliseconds. For severe aortic regurgitation, pressure equalization occurs rapidly because of a large regurgitant orifice and a significant diastolic backflow. This results in a very steep deceleration slope and a short pressure half-time, typically less than 200 milliseconds. Now let's talk about regurgitant volume and EROA. 60 millimeters or more means severe aortic regurgitation. I need you to remember that EROA and regurgitant volume answer two different questions. EROA tells you how big the leak is. Think of it as the size of the opening that the blood is leaking through during diastole. The bigger that opening, the more serious the valve problem. Regurgitant volume answers a different question: how much blood actually leaks backward each heartbeat? This is measured in millimeters per beat and tells us how much extra blood the left ventricle has to handle every cycle. Now let's talk about how these two are actually connected. These measurements are connected because regurgitant volume is calculated using EROA and the regurgitant jet VTI. Remember, EROA represents the size of the leak, the VTI represents how much blood flows backwards through that leak over diastole, and together they determine the total backward volume per beat. For grading severity and for the registry, severe aortic regurgitation is defined by either a regurgitant volume that is greater than or equal to 60 milliliters or an EROA greater than 0.30 centimeters squared. You may not calculate these on every patient, but they are very important to understand. Another topic I want to talk about is holodiastolic flow reversal. This is one of the strongest and most reliable signs of severe AR. If you see blood flowing backwards in the descending aorta for the entire diastole, that alone tells you AR is severe. Using pulse wave Doppler, sample the descending thoracic aorta, usually from the suprasternal notch or a high left parasternal view. If you see blood flowing backwards during the entire diastole, that means the aorta is literally draining into the left ventricle. If holodiastolic flow reversal is present, you can confidently call the regurgitation severe. As a quick summary, the three critical measurements in AR are the vena contracta, the pressure half-time, and the regurgitant volume. So now let's talk about what you must assess. As a sonographer, your job is to find the cause, measure the severity, and show how it's affecting the left ventricle. Here are some important tips for you as a sonographer. Always remember to put the whole picture together. Eccentric jets may look small on color Doppler but still be severe. Acute aortic regurgitation may not show a dilated left ventricle just yet. And finally, if your measurements don't match the clinical picture, stop and reassess your Doppler alignment, gain, and the views. Aortic regurgitation is not about one number. It's about understanding flow, physiology, and consistency. Let's talk about acute versus chronic AR. Take a look at this table right here. One important clinical difference to remember is how acute and chronic aortic regurgitation affects the left ventricle. Acute regurgitation can cause sudden pulmonary edema even though the left ventricle is still normal in size because it hasn't had time to adapt. Chronic aortic regurgitation, on the other hand, develops over time and slowly stretches the ventricle as it adapts to the ongoing volume overload. Feel free to pause the screen or take a screenshot of this slide. This acute versus chronic comparison is very important to both clinical practice and the registry. Now let's talk about treatment. So once aortic regurgitation is identified and accurately graded, treatment depends on the severity of the leak, the patient's symptoms, and how the left ventricle is responding over time. Management can range from medical afterload reduction and serial echo monitoring to definitive interventions such as surgical aortic valve replacements, aortic root repair, or TAVR in selected patients. From the echo standpoint, our role is not to choose the treatment. It's to accurately quantify the regurgitation and clearly communicate those findings so the clinical team can make the right decision. Now let's return to this registry power slide, because at this point, nothing on here should feel random anymore. Every single finding on this slide is telling you the same story, just in a different way. Aortic regurgitation is a volume overload problem, so whether it's a wide vena contracta, a short pressure half-time, and a large regurgitant volume or holodiastolic flow reversal, they're all showing you rapid pressure equalization and severe backwards flow. And that is exactly how the registry thinks. If you see any one of these, you should already be thinking this is severe aortic regurgitation. Here's a final registry recap. Aortic regurgitation is a diastolic valve problem that causes volume overload of the left ventricle. Severe AR is not diagnosed by one number, it is diagnosed by patterns. 1. A wide vena contracta tells you the leak is large. 2. A short pressure half-time tells you the pressure is equalizing quickly. 3. A large regurgitant volume or EROA tells you a significant amount of blood is leaking backwards every beat. And finally, holodiastolic flow reversal is your strongest Doppler marker of severe AR. If you see any one of these, the correct answer is severe aortic regurgitation. Well, that brings us to the end of this lecture. Thank you so much for allowing me to help you today. Stay tuned for the next one. If this helped you, subscribe so I can keep helping. Don't miss the next video.